What is happening, Floridians?
Too cold.
How is the weather in your neck of the woods? Today, the most important thing to talk about is the weather. I am your host, Alberto Rullan, and I'm going to tell you that it's going to be cold tomorrow.
Very, very
Question about it.
the coldest day of the winter so far. Tomorrow.
I am going to guarantee you tomorrow a pleasant, cold day.
Yes, it is.
Well, oh, we have some. Oh, Maria Camila is trying to join. Hello, Maria Camila. Welcome. Okay, good. Well, today I am excited to talk about one darn interesting topic. Do you think people are going to come late because it's cold? Is that what's happening? Is that why they have all the half of the team not joining? The other half of the crew. Mirta, how are you doing? I haven't seen you in a long time. You haven't talked in a long time. I've seen you there, but I haven't heard you.
Exactly. I've been around. I've been listening to all the classes. I'm here. Everything's okay. I'm cold.
Did you gallop today?
Yeah.
Sweet.
I mean, some of them were jogging, some of them were galloping, but it was freezing. At one point, it started raining. And when the rain started hitting your face, I was like,
oh my.
It's terrible. It nearly reminded me of the time when I was galloping in Ireland. That was rough.
That must be fun. Must be a lot of fun to gallop at 30, 32 degrees.
Yeah.
Well, let's get on it. Today I really want to touch this topic, which is the feet, and I'm gonna open up my presentation. Coming up. Awesomest. Oh, hey, you have two more people. Oh, welcome, Salma and Gigi. You almost missed it because I was about to close it, but I figured I waited 2 more minutes for anyone. Oh, Santiago wants to come in too. I wanted to close it in because once I start the presentation, then I don't know how to go back. But today we're going to talk about the feet, and I am very happy to show you some interesting PowerPoints that we put together here just for you. And I want this to be very interactive, okay? I think the feed is a very interesting structure. So I want to be interactive. I want you guys to just stop me, ask me at any point, and I know a lot of you will have questions because feet are just a very important part of the horse. So check it out. This is a case from Dr. Lichoa. And I want to start.
Come on, sweetheart.
I want to start. Oh, sorry about the echo. I want to start with this. So obviously this horse is lame on the left front, correct? Obviously the horse is lame in the left front. And there are only a very few diseases that can cause this. Very few. However, it could be very confusing because we can see how this horse just does not want to lift that foot at all. You see, this horse is having a defect of protraction. The foot is the whole leg is not coming forward. He's in so much pain that he doesn't want to bring it forward. And if you remember previous lectures, this could actually be an indication of shoulder pain, right? Because a horse that has a lot of shoulder pain will have a hard time bringing that leg forward. There's so many things that could cause this problem, but The first thing that you think when this is happening is, one, this horse could have a fracture. That's the very first thing that needs to come to mind when you see a horse like this. The horse could have a very bad soft tissue injury, like a big tear somewhere. Or the horse can have an abscess. Those are the three most common problems that will cause this particular scenario. However, there are other things that will do it as well, such as a septic joint, right? A problem in the joint, an infection in the joint, infection in the tendon, and others. What I wanted to start with this, I want to go back to the basics. What's inside that foot? Look at this. Look at this quick anatomical review. We have the P3, the P2, the P1, first phalanx, second phalanx, and third phalanx. And look at the correlation of where they are in the foot, right? Right here is the pastern joint, which is right here. Or we call that also the distal interphalangeal joint. Distal interphalangeal joint. Then we have the coffin joint. Sorry, the proximal interphalangeal joint and the distal interphalangeal joint. I re-talk. The pastern is the distal interphalangeal joint, and the coffin is the distal interphalangeal joint, and the pastern is the proximal interphalangeal joint. Sorry about that. Then obviously we have a hoof wall, the lamina. This is a very basic presentation of the anatomy. But within that foot, there's so many soft tissue structures. I mean, look at this. There is a digital cushion. There is an impar ligament. There's navicular bursa. There are collateral ligaments. There's a deep digital flexor tendon coming right here in yellow. All these structures are very important. Could get damaged, could get injured, could broke. They all can break, and they all can get significantly affected. That would cause a significant lameness, or they might get slightly affected, and then the lameness is not as significant. That's why it's so tricky to deal with the foot. Now, right here is the coffin joint, and we talked already about the third phalanx. Now, this is what it looks like more in the live version. Check it out. This is a live specimen. In this live specimen, you can see even deeper, even in a more granular level, how these things look like. Look what the digital cushion looks like. The digital cushion is has many functions, right? And one of them is exactly what we talk about. Is about cushion. Look at the flexor tendon. What does the deep digital flexor tendon does? Well, it brings the leg back. The leg is in the front, brings it back, and that is used for propulsion. Extremely important to actually move the leg. That's what the deep digital flexor does. It flexes the digit. Right in this area is the navicular bone, and this little space right here is the navicular bursa, which is a very common structure affected in quarter horses, for example. Now let's see how this bone right here is connected to the hoof. Everybody talks about the lamina, right? So there is a sensitive lamina, which is the one that's connected to the P3 bone right here. And there is an insensitive lamina, and that's the one that is right on the outer. What does it mean by insensitive? It means that they don't feel it. This is no more and no less than your fingernail, right? This is your fingernail. It grows every 5-6 days or every week, and you cut a piece of it. So that's what that is. And the junction between the sensitive and the insensitive is going to be the white line. Now, coming further up, right around this area, we have some structures called the coronary corium. I'm not really going to get really deep into it, but what I want you to know is that this is where the hoof is made. There's a lot of cells being produced right here, and the hoof is made at a rate of about 6 to 10 millimeters. 6 to 10 millimeters per month. All right, 6 to 10 millimeters per month. Now, Further up and more important is coming up this tendon over here that is called the extensor tendon. What does the extensor tendon do? It helps to bring that leg forward. Very important datum is that the extensor tendon and the deep digital flexor tendon are connected to muscles further up in the leg. And those are the muscles is what move the leg. The tendons connect the muscles to the bones and the joints. Good. Basic anatomy 101 done. Any questions before we go further forward? No questions. Very important for the rest of the lecture. So, whoa. Good. So, this is a 3D model that I made because one of the most important things about the foot is that it's not just the bones, but many times we think that the bone is actually what is the most important, which is, yeah, for sure, very important. But this is another representation of, look how many interesting structures they are. Why do I make this one? I made this one so you can see all these ligaments. I'm not going to name them all. That's going to be boring. I just want you to see that there's a ligament here joining this bone. And look at all these ligaments in the pasterns. Tons of ligaments in the pasterns. There are collateral ligaments. There are ligaments that, multiple ligaments that go from up here to the navicular bone. Look at that. Oh. Right here, you can see it going to the navicular bone. Look how cool that is. And there are ligaments that go into in the fetlock area right here from the cannon bone to P1. There's a pattern here that you see here is that every bone is connected with a ligament. So every bone in the distal limb is connected to another bone with a ligament. Why do I say in the distal limb? Does anybody happen to know a joint that does not have collateral ligament? Trivia question. Put them in the chat. Which joint does not have a collateral ligament? Most of them do, but there's a very important one that doesn't. And where's the chat? Oh, I see it. Oh, yeah, you got it. It's the shoulder joint. The shoulder joint does not have a collateral ligament. So remember that, because if you are ever here that you broke the collateral ligament of the shoulder, you better change doctors. So now here in blue and red, you can see some tendons. In blue, it's going to be the deep digital flexor tendon coming all the way down to the third phalanx. And in red, you're going to see the superficial digital flexor tendon attaching right here to the second phalanx. And of course, the extensor tendon that I show you right here in the front. Look at all these ligaments. How cool is that? There's collateral ligaments. There are cruciate ligaments in the fetlock. There is ligaments to the navicular bone. You name it. So this is what a normal radiograph looks like. Look how interesting. This radiograph doesn't appear to show as many structures as these horses have. We have the first phalanx over here, P1, P2, the navicular bone, and the P3. We barely see any of the soft tissue structures, and yet they're so important. That's why one of the most important emerging diagnostics in horses is actually the MRI, because with the MRI we can see a lot of soft tissue structures. We can see the lamina here, we can see the tendons, the ligaments, the collateral ligaments, etc. I put it next to each other so that you can see what it looks like in real life and what it looks like in radiograph. Now, trivia question, not trivia. What percentage of lameness is estimated to come from the horse's feet? Let's play a game. Humor me. Put it in the chat. Participate. Participate. Move your fingers. What percentage of lameness is estimated to come from the horse's feet? Someone guess. Just guess. 90%, Valerie, good. 60%, Santiago, good. 50, good. 70, thank you. Thank you for participating. We are pretty close. It is about 95% of the all lameness estimated to come from the horse's feet. They estimate about 95%. Now, in our practice, that is skewed. Skewed means in our practice is different. Why? Because we act as a referral center. So horses that come to us have already been seen by the farriers, or maybe have been seen by other veterinarians. So they have been already evaluated. And if the problem is in the feet, it has already been caught up. But in total, about 95% it is. Very good. So, how about the most common causes of lameness in the foot? What are the most common? Put them in the chat also. What do you think is the most common causes of lameness in the foot? Abscess, laminitis, navicular. I get abscess, laminitis, navicular. Yeah, all those are very common. You got it right. All of them are very, very common. Abscesses is one of the most common ones, and that usually gets handled by the farrier, the trainer at home. But I would say abscess probably would be the about the top one. Then navicular and laminitis, depending on the breed. But even before abscess, there are other simpler things that are more common, which the farrier handles very quickly. For example, shortened toenail, sole pain, flares. A lot of those things are very, very, very common, but the farrier handles it a lot. As a matter of fact, but farriery has evolved so much that there are so many good farriers out there now that a lot of those things almost don't happen to the degree that they were happening 10 years ago, which is super cool, very interesting how fast it has evolved. Veterinary-wise, abscesses, laminitis, and navicular are definitely, yeah, bruising, exactly. That's exactly what I was talking about, Mirta. Laminitis, abscesses, bruising, navicular, definitely the most common ones. So between laminitis and abscesses, I would probably say that the abscesses are probably more common. However, I don't have the true statistics for that. So that would be a total guess. Now, this is what an abscess looks like from the bottom if we are lucky. And we see it on the left-hand side. You can see the abscess bursting from the sole. And on the right-hand side right here, you can see a gas pocket right here. This gas pocket, if you can follow it in the radiograph with the dot, look how it goes all the way from the sole. That's why it's called subsolar. And it goes all the way there, and it goes up, check this out, goes up, 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 dissecting by the white line right here, and it comes up through the coronary band. So this is a very large abscess. This makes these horses very lame. 4 out of 5 degree, non-weight bearing, quite lame, quite lame. Treatment for it, it can vary, but the most common treatment for it is just soaking it with Epsom salt, a little bit of iodine, 2 to 3 times a day. Boom. 3 or 4 days later, they're out. However, some of these abscesses could take a very long time to come out. Yesterday, actually, we had a patient that came to the clinic that the abscess have been going on for almost 3 weeks, to the point that I was starting to get worried, and I told my client, hey, we better check this horse. We better actually radiograph it because it could be something else. I have also seen lamenesses that look like an abscess, smell like an abscess, and it's actually a bone fracture. That does happen. So as a rule of thumb, what I tell them is if the abscess have not burst out within a week to 10 days, I'd rather take some radiographs. That way we can either find it in the radiograph, just like you see over here, or we actually can dig it out like we did right here, where the farrier took his hoof knife, boom, open it up. 3 days later, this horse is going to be good to go. We can put the shoe back on, and excellent. What causes an abscess? Some of the most common questions I get. What causes an abscess? Well, we are not 100% sure all the time of what causes an abscess. Now I can tell you one thing. When we put a nail in the horse's foot, if that nail gets really close to the sensitive lamina, to right here, that we were talking about, if it gets really close to this area right here, to that sensitive lamina, that nail can cause an infection, and that infection will cause an abscess, and that is very painful. The treatment is the same. You remove the causing agent, so you remove the abscess, you remove the nail, and you soak it. 3-4 days later, the horse will be good to go. However, I have seen some of these ones that will last 2 to 3 weeks before getting better because they got really damaging in the sensitive lamina. Another very common question that I get on abscesses: hey, do we treat it with antibiotics? Most of the time, we do not treat it with antibiotics. However, if we suspect that it's really close to the foot, we can put them in some antibiotics. Excuse me, if it's really close to the bone, we can put it really close to if it's really close to the bone, we'll put some antibiotics. My favorite is doxycycline. It works out pretty well. Have good penetration in that area, and very effective long term, very long term. Now another question that we also get: is it true that if we give bute, the abscess takes longer to come out? I am not sure, but I really think it might. I really think it might. Sometimes they load these horses with bute at home, and it seems like they might take a little longer to burst out. I don't have no scientific evidence. I really don't have any data that can tell me that an abscess will take a lot longer to come out because the horse have bute or not. But maybe it does. It's just so painful that bute doesn't do anything, and that is another really good indicator that the horse could have an abscess because they don't get better with bute. Good. I think I covered most of the things related to abscess. Dr. Lichoa, comment on abscess. Anyone has questions? Abscesses are very common. If you have dealt with an abscess, if you have ever dealt with an abscess, you know that they could be frustrating.
Abscess, they can start as a simple thing to resolve, and they can turn south. They can be also very dangerous if we don't fix it on time. So abscess always has to be addressed very aggressively to try to recover the horse as much as possible.
Yeah, I agree, and that's why we recommend radiographs. If they treat it at home for several days, 7 days, or even sooner sometimes, to get a good diagnostic approach on it. When I was starting veterinary medicine, this was one of my most frustrated diseases because it looks just like a fracture. The horse is so much pain, you feel like the horse had a fracture. Now, let's jump to the next disease that we talk about, laminitis. What is laminitis? Laminitis is the I call it the cancer of horses, because horses, they don't get a lot of cancers, right? Horses have evolved so much in the wild that if they used to get cancer, then they were probably eaten by lions or by wild animals. So we don't really have a lot of cancer in horses, other than some skin diseases. But this particular one it reminds me of it, because we still do not have a good cure for it. We don't. Some horses all of a sudden do a miraculous recovery, and some horses perish to it. So it's a very, very tough disease. But this is a more or less an idea of what it is. I want you to look in the left. This is the hoof wall over here. And the red part is what I was telling you, the lamina. It works like a Velcro. We all know that. And what it does is it attaches the bone to the hoof wall. That's what the lamina does. So when that lamina gets sick, the attachment to the hoof wall fails, and this bone does what you're seeing here on the right hand side. It kind of looks like it rotates down right there. You almost see this bone rotating down just like that, and you can see a separation. Look at that separation between the bone and the hoof wall. Look at the distance right here between this hoof wall and the bone, and right here. It's obvious that it's separating. It's separating so much that you can see a gas pocket right here. This is probably in the white line, a gas pocket, or so much inflammation that we can see what we call radiolucent line, which is the black line right there. So there are different types of laminitis. One of the most common questions I get is, hey, what's the difference between laminitis and founder? Well, that is a three-day question probably, but all I can tell you is that some people use it interchangeably, or some people talk about foundering the distance between this bone right here and the coronary band. Oops, and the coronary band right there. That's what some people call foundering. Good, check this one out. This is another example of laminitis. If you can see, it's a little bit different. This particular one has been going on for so long that this bone looks like a ski jump right here, right there. That just tells you that this has been going for a very long time. It's called chronicity. It's very chronic. This horse has been with laminitis for a long time. Important thing to look is at the sole depth right here. So there's good sole depth. Sometimes a horse has no sole depth, no sole between the bone and the outside, between the bone and the hoof, nothing. That is very painful, very difficult to recover, by the way. So check this one out. Which one's normal, which one's abnormal? Right? The one on the left is very nice, very normal, has a very smooth, healthy bone, great attachment to the hoof wall right here. Now I want you to look at this black line. That's normal, okay? That's not white line disease. That's not laminitis. That is normal. Now, in contrast, let's take a look at the one on the right. Look at the distortion right here in the hoof wall. A lot of distortion. So this horse has lost complete attachment to this bone, and this bone is suffering. This bone looks weak, it looks rough. Right here, it looks like it has a lot of reaction, a lot of remodeling. This is what we call an angry bone, an angry bone. Plus, there's an abscess right here. This black shadow over here is an abscess. Why does the horse with laminitis abscess? Well, because some of these areas start dying, and what does the horse do in order to get these dead particles out? Well, it pushes it out. by creating an abscess. That's what happens. One of the things that we can do in horses with laminitis, we could do a venogram. This is what you see here. In this venogram, we evaluate what is the blood flow of that hoof. If the blood flow is good, then we know that this horse actually could carry a good prognosis. The horse might do good. We can also choose the horse according to the venogram, which is one of the very, very good tools that we use for showing horses with laminitis. Now, check this one out. Oh, laminitis. Wait a minute. We can spend obviously many days in laminitis, but anyone has ever have a horse with laminitis? Anyone has any experiences with it that want to share or have any questions about it? Because this is the most common disease ever to be controversial in the equine business. So everybody asks about laminitis before I move on to other problems. Oh, we're so quiet today, guys. Don't be shy. Well, if you think of anything, you put it in. If you don't think of anything, just don't put it in. It's all good. Huh? So, how do we treat laminitis? How do we treat laminitis? There are 1,000 ways to treat laminitis. One of the most common ways to treat laminitis is do nothing, believe it or not. One of the most common ways to treat laminitis is do nothing. So I'm going to go from the most crazy ways to treat it to the least crazy. Have you ever heard of people bleeding animals? Bleeding. So some people would bleed back in the days, and there are still people doing that. They remove a lot of blood. I'm talking about 5 gallons of blood. So that used to be a treatment for laminitis. And I have recently heard that some people still do that. Now, I want you to think about it. I want you to think outside the box. Bleeding animals. Why? Alfredo, yes, you heard about it. Good. So, why would someone, think outside the box for a minute. Why would someone bleed 5 gallons of blood out of the horse? It sounds crazy. It sounds totally crazy. But this was the rationale. Bear with me. The rationale was the following. I'm about to tell you. 1. If the blood is toxic, then you're removing the toxic blood out of the horse, so you're removing toxins. Rationale number 1. And Mirta got it. The rationale number 2 is that you remove all toxic blood and the body starts producing new blood and start regenerating its own sources of hoof, brings new stem cells, etc. We know by plain biology that it takes about 7 days for the bone marrow to kick in and produces a new red blood cell. So what I have heard from people who actually do this is that they get so much blood out until the blood starts getting dizzy. And that's about when they stop. Then they wait for that horse to start recovering. Apparently, the results were relatively positive. I don't think many people do this anymore that I know, but I do know that some people still do it, and I know that it was practiced back in the days. Bleeding the horse to get new blood, regenerate, and start healing the horse. So that's an uncommon way to treat laminitis. Another way to treat laminitis is to give them some anti-inflammatories like bute or Banamine and put therapeutic shoeing to relieve the pain based on the biomechanics. So that's another way. Now, other way I include regenerative medicine. Some people, you see how there's a lot of blood right here in the venogram. some people, what they had been doing is putting stem cells right here instead of this contrast material. They put stem cells, and they had some mixed success with it. It wasn't really super popular after a while. It's trying to come back. It's trying to come back again. And lately, we have also been doing oxygen hyperbaric chamber for horses with laminitis with some relative good success. The success rate depending on how many treatments we can do. The more, the better. When we pass the 40 treatments, that's when we have seen the significant advantages. And we have some horses that have come really bad, almost with the bone out, and the Tolicho has a patient that is actually jumping again and doing fantastic. So that's super interesting. The question is if I have a preference between Bute or Banamine to control the pain. No, I don't have a preference, but some horses do better with Bute, some horses do better with Banamine. So we can try one or the other. We historically we put them in Bute first, I believe, just historically, because they say the community says that the Bute is better for bone pain, and the Banamine is better for abdominal pain. So theoretically, in the community, we like to use Bute better, but in reality, I have seen many horses respond better to Banamine as well. Other anti-inflammatories that we use are DMSO IV. There are some people also using aspirin. There are some people using Tylenol, and with acetaminophen, a lot of acetaminophen. What else can I think? And all kind of herbs. There's a lot of herbal products being used because this is a disease that is so complicated and we haven't found the cause yet. There's so many treatments available. So many treatments is crazy. Now, another treatment that we used to do and that we use less frequent right now, remember that deep digital flexor tendon that I show you that comes all the way here and attaches to the P3 bone? So back in the days, we used to cut it. We still cut it, just not as commonly. But the reason we cut it is to actually drop this heel down and make it more normal looking like this. But more importantly, to relieve the pressure from the circumflex artery. So we relieve the pressure from here by cutting that tendon. And by relieving the pressure, we actually get more blood flow. And if we are able to achieve that, those horses do really good. So if we are able to do this amount of blood flow, you see how there's a lot of blood flow right here? Boom. They do great with that. All right. Did I miss anything? I probably did because there's so many things. So I bet you learned something today. How about bleeding? Put me in the chat. How many of you have never heard of that bleeding before? How many of you that's new? Mirta, good. Yes. Yeah, thank you. There you go. Thank you for being honest. Right? Yes. Yeah, bleeding for laminitis. Very interesting. Please do not go and say that I told you to bleed a horse for laminitis, okay? I'm just telling you that that's what some people used to do, and some people actually maybe some do today, nowadays. All right, let's continue on the foot. Check out this radiograph. Normal on the right, abnormal on the left. Normal on the right, abnormal on the left. I'm gonna tell you the story of this horse, the one on the left. The horse on the left got a stifle injection. For those of you who are old enough to remember that back in the days, we didn't used to like to use triamcinolone. So the horse on the left had a stifle injected with 12 milligrams of triamcinolone on the stifle. I know this is not the stifle. This is the foot. However, this horse got that much. So most of these horses being put down, most of the Laminitis horses end up being put down? No, not necessarily. Thank you for the question. The question is if most of the Laminitis horses end up being put down. Nowadays, we actually can save a lot of horses with Laminitis. We can do really good, especially if we catch them early enough. We can save a lot of them, and if we can prevent the bone from coming out of the foot. The best way for bleeding, Sama, I don't know. I never bled a horse. I really don't know. I was just telling you what people do. I'm not promoting it. Please do not confuse. I was just telling you it's a very old way that people used to do, but I really don't know how they used to bleed them, or how they do it. I think that I was talking. I can I was talking to a doctor that did it one time in my life, and she literally was drawing blood from the jugular vein. I don't know. Honestly, I don't know if it's the best way or if there's a better way than another, and I have never done it. I rather go with other approaches such as anti-inflammatories, corrective chewing, hyperbaric oxygen chamber, ozone treatment, etc. Thank you for the question about bleeding. If any of you try it, you can report back and let me know how it goes. I'm not sure in the United States it would be a very accepted methodology anymore due to all the welfare controls, but I know that other countries might do it more. This particular one that I'm telling you was in Denmark, I believe. Good, thank you so much. So here's another. I was telling you about this horse that got triamcinolone injection. So triamcinolone is Vetalog. Why did this horse get Vetalog injection? He was lame. The horse was lame on the stifle, and we treated it with triamcinolone. There is a correlation between steroids and laminitis, and this correlation has been controversially put to the test. But I can tell you that in my experience, the correlation appears because this is one of my patients on the left, and this horse got the stifle injected with triamcinolone. Then the horse developed laminitis. The owner treated this horse as if it was an abscess because the owner couldn't correlate the injection with the coffin, with the front. She couldn't correlate that there was an injection in the stifle with the lameness in the front. So this horse actually was treated by I was in this case the secondary or tertiary veterinarian. I did not know about that there was a reaction, and the horse was soaked for many weeks, and then the horse was treated with acupuncture for many weeks, and she couldn't hold it anymore, so she called me. We went to see the horse, we took a radiograph, and this is what it looked like. So prime example of a horse that was treated with triamcinolone, developed laminitis, eventually developed an abscess that went all the way from the coronary band into the coffin joint. And what you can see over here is an infected coffin joint from an abscess that went all the way from the outside in. You can see here more abscess. All these black lines are abscesses. This horse definitely did not do very well. But coffin joint injections or coffin joint infections can cause severe lameness, like the horse I showed you at the beginning of the presentation. And that could happen secondary to other things such as trauma, steroid injection, toxicity, colitis, or diarrhea, you name it. Here's another one. Another problem with the foot. This one has the coffin bone fracture right here. You can see this line right here coming up. And this horse has a coffin bone fracture. This horse kick a wall. The most common way to get a coffin bone fracture in the hind end is by kicking a wall. Good news. Most of these fractures do really, really good. They actually have a great prognosis. If we put the horse in a stall, we can put a cast if you want to or not, or we can put some therapeutic showing or not. The question is, when detecting lameness or injections in the feet or bones in general, how do you know if you should use radiograph, CT scan, or MRI? Great question, absolutely great question. So, how do we know if we should use radiograph, CT scan, or MRI? The fastest imaging modality is a radiograph or an ultrasound. For the foot, we tend to go first to the radiograph. But we know that if the radiograph is absolutely clean and the horse is lame on the foot because we have localized the lameness to the foot, whether it's by hoof testers or by diagnostic blocks or etc., then I like to send them for an MRI. Can we do a CT scan? Yeah, we can do a CT scan. But why do we do an MRI? Well, let me backtrack. First, we do the radiograph. Then, if we don't find anything in the radiograph, we can go to the ultrasound. And those two are the most economically feasible. To answer your question, I think we're moving more into economics rather than just imaging. So economically, it's way easier, way faster to do a radiograph, to do an ultrasound. You can do that the same day, and it's about $500, 500, $600 to do both. And about 90 to 95% of the time, we can find it with that modality. Now, if we don't find anything with radiograph and ultrasound, then we start moving to what we call more advanced imaging, such as CT scan or MRI. We go for the MRI first because the MRI will give us a lot more soft tissue definition. And that's a great question because if we look here at this picture, look how many soft tissues do we have? Just minimum in just tendons and ligaments. We have 1, 2, 3 bones, and start counting. How many tendons and ligaments we have? We have 1, 2 tendons, 1, 2, 3, 4 ligament on this side, plus 4 ligament on the other side. That's 8. Plus 2 tendons is 10. Plus another tendon here, 11. Plus another ligament here, 12. Plus another ligament on the other side, right here, 13. Plus the cartilage. So we have about 15 to 16 soft tissue structures versus 3 bone structures. So the MRI is going to give us a lot more information. CT scan goes more towards bone. If we suspect that there is a fracture or something that is in the bone that the radiograph did not pick up, or that it's very early for the radiograph to pick up, then we send it for a CT scan. That's a great question because sometimes we can have a fracture. Did you know that we can have a fracture in the foot and the radiograph be clean? 100% clean. You might not see anything. Then the CT scan will actually see it. This particular fracture could happen and you see absolutely nothing in the radiograph. And then we send it for a bone scan. Good question. Thank you for asking. Now, the next one that I want to talk about is look at this radiograph, how interesting. This horse looks like a rat ate a piece out of this bone right here. You see how it looks smooth, 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 smooth? And a rat ate a big piece right here. That's called a keratoma. That keratoma could make the horses very, very lame if it creates an abscess. Or it could cause absolutely no lameness and you can find it almost incidentally or by mistake. And then the problem becomes, okay, do we take it out or we don't? Because a keratoma is almost, I want you to think about almost a benign tumor in the foot. Something, that's the way I want you to think about it. So if it causes lameness, we remove it. If it doesn't cause lameness, we do not remove it. So that's a keratoma for you. What else could cause lameness? Well, right here in this radiograph, now you have seen many normal ones, and I'm showing you an abnormal one. I want you to look at the bone position. Look at this bone position between the coffin bone and the second phalanx. There's a spur right here. There's a mineralization right here. So this horse has quite a bit of disease in the coffin joint. So that's another cause of lameness in the foot. That is coffin joint arthritis. Coffin joint arthritis. What do we do for this? I love to do regenerative therapy. We do PRP, alpha 2. We could do hyaluronic acid. We could do ozone. We could do steroids. We could do nothing. We could do shoeing. We can see here how the tip of this bone is coming up, right? And the heels are coming down. Yeah. However, if we increase the heels, we raise the heels, lower the toe, this horse is going to be way more comfortable. So that's another thing that if you have horses, you want to help your farrier, what do? You can help your farrier with radiograph so they can see where that bone is. You don't always see the bone when you're a farrier. Sometimes they're shooting blindly. So we take some radiograph, we show this to a farrier, the farrier can fix it, and the horse could do really good, really fast. Good deal. This is the Tolichua's and Santiago's case. Check this out. This is another common problem. Now I want you to look. I know this radiograph, this picture doesn't do justice, but look at this. Look at this right here. Where's the frog? There's no frog, right? There's a big hole. How about this one? Look at this. There's no frog. There's a huge hole right here. This horse had so much. I'm going to show you a video over here. Oh. Oh, the video is not performing to my expectations. Right there. Oh, no. Come on. What did I do? Here we go again. Hand tight. Look at that hole. Right. Hey, when the videos don't do that. Right here. Look at that video. Look at that hole where the frog goes. If this is not the case of the week, I don't know what it is. Thank you, Dr. Lichua, for letting us use this case. Right here. You can see that this horse is missing half the frog and there's a huge hole in there. And this started because of thrush, which is a nasty infection in the bottom of the foot. Here is a simplified version. I want you to look at the horse's foot from the bottom. And you can see on the right hand side, all this area is just full of dark infected material, right? Where you can see this, the collateral sulcus right here. You could have it in the center sulcus. Look at the picture on the left. You could have it on the apex of the frog, like here, right here, see? At the apex of the frog, right here. The sulcus, the central, right here. All that was just a big mass of thrush that went all the way almost to the bone. This is the radiograph of that horse. You can see right here how if you follow my cursor, we theorize, we suspect that it might go even so close to the bone right here. That was a great case. And this horse was very, very lame. So what did we do for it? We did a hospital plate. You can see over here that the farrier to Lichoa and Santiago, they cover it with a plate, they put some screws, and then they cover it with antibiotics. And voila, the Lichoa reports that the horse is doing amazing, extremely good, happy ever after. How to prevent it? Just keep the area clean, keep everything nice and cozy, well disinfected. Clean the stall, clean the stall, clean the hoof, clean the stall, clean the hoof, clean the stall. Well, we can talk about the feet for ages and days and nights. However, our time has come to an end, and it has been an absolute pleasure to spend time with you guys on this Thursday afternoon. If you have any questions, unmute yourself, make it a conversation, tell me about it. And if you don't have any questions, also unmute yourself and say hi.
Hi.
Dr. Lichoa, thank
Yeah,
you for the
very.
case. How is that case doing? Really good, right?
She's very happy. She called today that she's doing great, and she sent me a picture of the. I sent it to Santiago for today. He's doing much better and almost 100% sound.
Awesome. Good job. Good job right there. Hey Doug, have you ever done this bleeding thing for horses with laminitis?
No, I never did it myself, but I got an old blacksmith. My age is when I was at vet school. He did a couple ones, and that was. But he went straight to the hoof and he cut part of the wall of the hoof and let him bleed from there. That was crazy.
It's such a desperate disease.
Yes, it is.
We are just so desperate to try to find a cure that we're willing to try anything, anything.
But I think now with the days that we have, with the techniques and the resources that we have, we've been improving tremendously. So I think we much better now than before.
Yes, yes. Is anybody here not from the United States that wants to comment on laminitis? How is it treated in your country? It just varies so much. And anyone here cares to share? Mirta was telling us that they euthanize all of them over there, obviously, huh?
Nah, that's not really the case. But like back home, there's no more race horses for a while now, and even what's left of the horses, it definitely doesn't get the best care because back home, the vets, they don't exist as a vets for horses. They're just vets, and that's it. So it's a very broad spectrum of knowledge that needs to be applied for a horse. It's completely different than it is here in the States.
Yeah, it's also very, you need so many resources to treat this disease, so many resources, and of course, more horse owners want a quick fix and good to go, Good. Well, my kids, if there's absolutely no more chit-chatting here, it's about 7 o'clock. We're gonna call it quits, and I hope you guys enjoy the rest of your evening. Stay warm, go cuddle, and have fun.
Thank you.
I have a question.
Yeah,
What are we
please.
doing next week?
Well, if it's cold, I'm gonna be sleeping.
Well, the
No,
good news
I
is
mean, what's the class about next week?
Whatever you want. I
you
answer
pick
to
the topic.
whatever you guys request.
You pick the topic, we help you.
Salma, 4 a.m. in the UAE. Good job. Oh, Salma is probably the only one that's not freezing. She's in the Emirates at 4 a.m.
Ready to go to work.
Yes, you gotta go to work. What do you want to talk about, Gigi? No, you're muted.
I didn't know we had someone here from the UAE.
Oh, yeah.
Yeah, that's
Sometimes we have from Africa, from Colombia. We have from Ecuador. They just don't all join at all the time, because they forget, they sleep.
the time difference. That's all. I didn't know. That's cool.
So you have a topic that you want to request? Is that what's going on?
No, I have a couple different ones, but some of them I am doing my own research on. But I really, one day, if we're able to, I really want to come by and actually see the hospital that you have in Ocala, because so many of the videos in the course are like all the safety procedures and everything like that, and they're going through it step by step, and it's hard to really like I need to see it,
Come tomorrow. We'll be here. We'll wait for you.
Okay.
You can come anytime. You just let us know when you're coming, and we'll be here.
Okay, perfect. Thank you so much.
Give us like a day ahead.
Okay.
A night ahead, so we can be prepared.
No problem. No problem.
Very good. Yeah, you're welcome. Everybody's welcome, obviously, to come here anytime. I don't know why Mirta doesn't come. She drives through every day.
I actually don't. I live at the farm, so I very rarely actually leave the farm, okay? I'm stuck working 10-hour shifts. I got no time.
Job.
I heard the
I'll come when the weather is better.
The Grand Prix is going on right at the WEC, so I was like, let me just make like a whole weekend out of it. But if I go to Ocala, I have to come to the hospital.
Absolutely.
Yeah.
Absolutely. Let's do it.
Okay. Sounds good.
All right, guys. Thank you.
Thank you.
Thank
Good
you.
night.
Bye.
Good night.
Bye.